proud of my family.
For sure, GP.
Now we have our family as well. Dr. Q,
Right.
please.
Is that the Italian emperor who's next? Dr. DiBiase? All righty, Dr. DiBiase. Take it away.
Can you see my screen, sir?
Yeah, we're good.
All right. So today I'll be presenting a case that Dr. Q did together with Dr. Akinduro as well as with Dr. Sapsevitz. This is the QR code. There will be some interactive questions along the talk. If you want, you can either scan the QR code or go to polyv.com/Mayo Florida 165. And I will show the code again just to keep the lecture interactive. So we have a 60-year-old right-handed female from Central America. She was in her usual state of health, but 1 week prior to presentation, she had an episode where she developed abnormal speech with specifically difficulty naming objects as well as activities. She went along with her day and she went to a beauty parlor where she continued to have these abnormal speech difficulties. And she also had an episode where she stood up, she almost fainted, that's what she described, and her husband was able to gather up. There was no grand mal seizure witnessed, and she had some amnesia of the event. She was subsequently taken to a local hospital for further evaluation, and she was given steroids, mannitol, as well as anti-epileptic medications, and her symptoms improved significantly. At the institution, they obtained an MRI that revealed an intracranial lesion that was concerning for glioblastoma. So given the complexity of the case, as you will see in the next slides, the patient was transferred to the Mayo Clinic for additional treatment evaluation by our multidisciplinary team. As far as past medical history, the patient had a DVT in her right lower extremity, diagnosed around 15 years ago on anticoagulation with Coumadin for 1 year. She had a cesarean C-section delivery over 10 years before, and her mother also had a history of DVT and PE, and no social history contributory to the case. On physical exam, when she came to us, she was alert, awake, and oriented time 3. Her speech was fluent with good comprehension, repetition, and naming. Her cranial nerves were intact, and her motor function was intact throughout 5 in all extremities and no pronator drift. Sensation was also intact, reflex 2+ with no abnormal reflexes, and toes were downgoing bilaterally. So when she came to us, we obtained a new brain MRI, and you can see here on the left side an axial T1 pre-contrast. Okay, and then side by side, we have an axial T1 post-GAD, where you can see a lobulated, well-defined hemorrhagic lesion in the left middle temporal gyrus with peripheral edema, with also some compression on the occipital horn of the lateral ventricle. I don't know if we have radiology on the line and they want to comment further. And we also have additional sequences on the following slides.
Hi, good morning, everyone. It's Vishal Patel. I'm on. That's a fantastic description. As you mentioned, it is a hemorrhagic lesion, like we saw in the previous case of the cavernoma. We have some intrinsically T1 hyperintense blood products, and that suggests that we've got a methemoglobin stage of blood going on here, either intracellular or extracellular. And you have to be careful to make sure you look at the pre-contrast for this exact reason. Otherwise, it's tempting to call more enhancement than there is, or enhancement when there is in fact none. But we do, as you mentioned, have some peripheral enhancement here, which we'll look at some other sequences, I'm guessing, but often you see in aggressive tumors like glioblastoma, only very minimal enhancement at the rim, whereas the central aspect of the tumor is essentially necrotic because it's thought to be outstripping its own blood supply for the most part. And certainly in adults, if you have a mass that looks like this, unless you have a reason to say something else, it's a glioblastoma until proven otherwise.
Thank you, sir.
And
And
this
here
is
we
an
saw a sad.
interesting thank you, Vishal. I was just going to say this is an interesting lesion because I think Dr. Patel already alluded to the blood products, the contrast, and some indications. I think that in this particular case, what's going to make this case complex is the fact that if you look at the images that Dr. DeBiase is showing, you'll see that it doesn't appear like the lesion is coming to the surface. And this is a dominant hemisphere patient that is right-handed. We heard already the presentation. You may think, well, maybe in some areas it could potentially be coming to the surface, but in my experiences, if it doesn't clearly come right to the surface, even if you think in the images it comes to the surface, a lot of these lesions do not. So it makes it tough once you go in to try to plan where your corticectomy is going to be. And this is an argument to use a surgical approach that you guys are gonna hear about right now. But that's something to consider as you're looking at the images, because you're already thinking this lesion must come out. The patient is symptomatic. I think that we're gonna have to do an extensive workup, but at one point we need to devise the surgical approach. All right, keep going, Dr. DeBiase.
Actually, could you leave that sagittal up for just one quick second? I want to ask the students a question here. Any students, why is her repetition intact? What would your explanation be for that anatomically?
Maybe we can have a student, Noor. Let's see, we have Noor right here, and she's
I have a
joining
question
us
about that
from far
later.
away. Yeah, oh, you do, but maybe then later we'll see the answer. So go ahead, Noor. Dr. Stabsevich, who's been working with you and translating these paradigms into Arabic, is asking you a question.
Her repetition is intact. It might be affecting Wernicke's area, if I'm not mistaken.
Well, if it was affecting Wernicke's, her repetition would be quite impaired, right?
Oh, repetition is impaired, right, in Broca's and Wernicke's.
So in this case, she can repeat. She's got a very severe anomia, naming problems, but she can repeat fine. So how do you explain that? Anybody? How do you explain that anatomically? What parts of the brain have to be intact to be able to repeat speech?
Let's move to Manuela. Manuela, what parts of the brain must be intact, for this patient to have this lesion, and still be able to repeat?
So it would be probably I think it's called transcortical aphasia.
Okay.
So something like that. I'm not quite sure.
So repetition requires that perisylvian loop to be intact. And what I mean by perisylvian is the superior temporal gyrus. That includes SLF3 and arcuate fasciculus out to those frontal speech motor centers. So if you think about the brain and what it does and what we need to do when we repeat, the first thing we have to do is we have to process those speech sounds we're hearing, right? If you can't do that, you can't repeat. And that is localized in the superior temporal gyrus, sort of that mid superior temporal gyrus, superior temporal sulcus. Then the next thing we need to do is take speech sounds in our head and put them together to make those words that we just heard and processed. And that's more posteriorly in the superior temporal gyrus and curving around to the supramarginal gyrus. Then we have to send that information to the speech motor areas to express that and articulate that. So that goes via SLF3 and arcuate. That's our dorsal phonological route to Broca's area. And there's a lot of debate about what Broca's area does. We know it's not actually involved in speech motor execution. It's something before that. But after Broca's, processes that information, then it goes to the ventral premotor cortex to activate those motor programs, and then to primary motor to actually move those parts of the mouth and so on. So that whole perisylvian region has to be intact. And you can see in this image, it is. There's some edema, there's probably some mass effect on it, but it seems to be preserved. And the lesion sitting in the middle temporal gyrus, which is a known cortical semantic area. And there are some critical white matter tracts that would contribute to anomia in that area. I don't know if anybody can identify those for me.
Let's elevate this one to Diogo.
Yeah, so if I understand the question, you were asking me which tracts would cause anomia in this particular location.
Yeah, what are those subcortical tracts that Dr. Q and I would pay attention to here?
So I would pay attention to arcuate fasciculus here, for instance, since it would be connecting a vernix to Broca's, potentially it could cause anomia. SLF, as you mentioned, and potentially even IFOF.
Yeah, definitely IFOF. So IFOF is one of those tracts that runs down through the temporal lobe and then shoots up to the frontal lobe. It's definitely important for semantic processing and naming. Yeah, you're right. I mean, arcuate probably has some origins kind of in the superior border of this thing. But IFOF was one that I think Dr. Q, you and I kind of looked at a lot of imaging trying to figure out how to try to spare whatever was intact or left for that with that.
Beautiful. Well, I think that what Dr. Salcedo illustrates is, number one, the lesion has, in my opinion, the way I think about it when I discuss this case with him, I have two things that I need to worry about. I need to find a safe entry zone. I go back to what Mateo was saying. He was finding the safe entry zone in the skull base. In this case, the surgical approach, the incision, the bone is less complex. Here, the safe entry zone is what's going to be the part of the cortex that we can enter safely and cause the least amount of disturbance to those neurons that are going to be potentially connecting different parts. And the second one is, once we are into the lesion, how do we monitor those white matter tracts that Dr. Salcedo is illustrating, so that we also cause the least amount of disturbance to the patient's well-being? All right, so that's really is. So Dr. Salcedo is illustrating by asking you guys all these questions is a tremendous complexity that it goes along this. And this is why, to me anyways, when I do something like this, there's no better way to do it than to do the patient awake and constantly hearing the feedback from Dr. Salcedo as we're moving along and separating this lesion from the brain.
And it really highlights again, Dr. Q, that we're taught these antiquated, oversimplified, and I would argue somewhat inaccurate models of language. This fascination and fixation on Broca's and Wernicke's. We really, as clinicians, need to move past that, or we're going to do harm to our patients. So, I would encourage all the students here to really dig into that literature and think about the brain as sort of connectomics and connectivity. That's all connected, and think about the language as a process or processes, not by anatomy. So instead of saying Wernicke's and Broca's, think about, lexical semantic processing, phonological processing, and things like that, because that's the level I think that we need to be thinking about when we think about the brain and surgical mapping.
I love it. I like to think, Wernicke's and Broca's is like coming to the United States and finding out where is Texas and where is, Florida in general. But we know that within those states, there's a tremendous heterogeneity and variety. And to be able to move from point A to point B, you're going to have to take Highway 95 or Highway 10, depending on the state, and understand some of those more intricate details. So, but beautiful. And I think that the best way to dig into that literature, David, is exactly what you're doing. You do your course also, your regular monthly meetings where you go through all these figures. And I think even Gaetano is going to have some figures right here that you are beginning to put together with Eric Middlebrooks and looking at all those pathways and putting arrows around, and people beginning to understand that this is more, complex. These are circuits more than just territories, I guess. That's the best way to think about this. All right, let's see what we get next.
Thank you so much, Dr. Sapsevitz. And this is just an axial flare as well as a coronal T2 to show the peripheral edema associated with this lesion. And you can see on the corona that Dr. Q mentioned, it does not seem like it comes all the way to the surface. And here we have an axial SWI, susceptibility weighted image. I don't know if Dr. You can see the characteristic blooming of.
Yeah, maybe Dr. Patel, you can comment on this one, because That's what I was saying about the issue of whether or not the lesion comes to the surface at this point. What are your thoughts, Vishal?
Yeah, absolutely. Dr. Q, I agree with you. It looks like it stops, at least on this sequence, it looks like it stops short of the surface. So there is potentially some cortex at risk during your approach to this lesion. When you have a big hemorrhage like this, it becomes quite challenging sometimes to characterize the mass itself. So some of the internal signal characteristics are going to be overrun by the blood products itself. That's why in the previous case too, sometimes it can be difficult to diagnose the cavernoma on the initial hemorrhage because everything is just obscured by blood products, and you may have to wait for that to resolve before you can see what the underlying lesion is. But yeah, I agree. As to your question, it looks like it's short of the surface here.
Beautiful.
Thank you. So at that point, just to rule out any other primary cancers, and we did a full metastatic
Well, let me ask you before you say anything, let me go back. Let me see one of our students right here. Let's see, is Loisos here? Loisos, you ready to rock and roll? I guess Loisos is not here. Let's see, Giselle, is she here?
Yes, I'm here.
All right. So what's the differential diagnosis of this lesion? And why did Dr. DeViase order a CT of the scan, chest, abdomen, and pelvis? You have a young woman, how old is she right now, Gaetano? 60?
in her early 60s.
Early 60s, all right? And you have this lesion, is hemorrhagic. What lesions go to the brain that can be hemorrhagic? Name two.
What lesions?
I'm not going to make it too complex. Yeah, what primary lesions can go to the brain and be hemorrhagic?
I see lesions in the liver, but I'm not quite sure if that.
Liver, yeah, maybe, but not in the top. All right, I'm going to go to Omar. Omar, what lesions can be in metastatic and go to the brain and are hemorrhagic? Name two.
Thank you.
All right, I guess Dr. Omar is not here with us, and just to remind the students, being present is more than just having your name here. Let's go to Dr. Adrian Safa. Dr. Safa.
Yes, good
Give
morning.
me two lesions that are primary that go to the brain and they can be hemorrhagic.
All right, so I think would be I'm thinking about lung, breast, kidney, and colon. I'm not quite sure.
Okay,
the two.
I'm going to give you one of them, kidney. All right. What else can go to the brain, but none of the other are hemorrhagic classically? What other brain lesion can be in the body, go to the brain, and can be hemorrhagic?
We can have also maybe a tumor of the skin like melanoma.
Excellent, beautiful. All right, Dr. DeViase, anything else to add to that point?
Yeah, no, I definitely agree. Kidney melanoma on top of the differential, and given
for hemorrhagic ones, of course.
Yeah, for hemorrhagic,
the more classic, of course, more classic metastatic to the brain would be lung, would be breast,
breast
no question about it.
case,
But I'm talking about hemorrhagic. You know what I mean? That was the question.
Yeah, but we didn't
Right?
see any evidence of that on our workup. So at that point, just a quick question. If you can log in on the website.
Beautiful.
Here you can see a tract in red, and you can also better see it on the next slide. So what is the name of the white matter tract that connects the frontal opercular cortex with the posterior temporal cortex depicted here in this tractography? SLN, arcuate fasciculus.
I was going to say, Gaetano, for some reason, I logged in and now it's asking me some sort of V1, V2, V3, V7 question. So I'm not quite sure how that happened.
Diogo can go back to the first question.
Oh yeah, maybe we go back to the first question, Joe. Let's see, is that?
Did you update it, sir? Because it should go straight to this one. That's the one I have.
Oh, okay, got you. I got you. It is now.
Yeah.
Good. All right, let's see.
Thank you, Dio.
Maybe while people are thinking about this one, I'll just add that we pay sort of careful attention on the radiology boards, at least to how this question about the hemorrhagic metastases, brain metastases, is asked, because certainly while it is the case that melanoma, thyroid, renal, when they do metastasize to the brain, they are more frequently hemorrhagic, just because the frequency of the more common tumors, lung cancer, breast cancer, is so great. The overall incidence of those tumors just being the underlying tumor when you have a hemorrhagic brain met is still more likely to be just one of the more common tumors in general. So it's just for the students, be careful how they ask the question. Is it the overall most common hemorrhagic brain met, or is it the hemorrhagic brain met that, or the brain metastasis that tends to be hemorrhagic most often?
Yep. Very good point. Thank you, Richard. That's a very good, because definitely breast, lung, are by far, the incidence is way higher, than the other diseases. All right, so we have an answer for this one?
All right, so the answer is B, arcuate fasciculus.
And this is what we were saying, this is what you're doing more often, this is the picture from this patient, isn't it? Did Dr. Middlebrooks created that map for us for this patient, or was that a
This is
normal patient?
available
That he
from the
just...
website. There is a repository with
This is from the connectome, yeah.
definitely.
Gotcha, because
So
he's
what
been doing
deficit?
some of these pictures.
Yeah. What deficit is caused by a lesion of the arcuate fasciculus? Global aphasia, Broca's aphasia, conduction aphasia, or Gerstmann syndrome? All right. So for the interest of time, since we don't have much time, the answer is conduction aphasia. So as we were discussing, characterized specifically by intact auditory comprehension, coherent speech, but inability of repetition. And then, so we obtain a functional MRI, even the location of the lesion, and for surgical planning. And again, here you can see motor tongue, and on the right side, most importantly, you can see language. So right side, left side language dominance, and you can see right superior to this lesion, but it was kind of alluded earlier. Functional MRI is a good indication, ideal for surgical planning, but it's really the patient, the best source of information, especially with this hemorrhagic lesion, the neurovascular uncoupling. Sometimes there may be function, or there may be false positive with you see on the functional MRI. But then when we go in with the OR, and we stimulate, there is no eloquence in that area. But most importantly, also here, we obtain a DTI. And as earlier discussed, you can see the proximity of the lesion to the IFOF as well as the ILF. Very important for her surgical planning for the deep component of this lesion. So on top of the differential, as was discussed, we can have a vascular malformation, as well as we cannot rule out GBM or metastasis, as discussed extensively, even though the workup was negative for those. So we discussed with the patient, and the plan was for a left awake temporo-parietal craniotomy, given the fact that she was symptomatic from this lesion and there was a bleed as well, with intraoperative neuropsychological and electropsychological monitoring. But before proceeding to the surgery, we had her being evaluated by Dr. Sapsevitz, and maybe you can comment more, but I think it was very important that you got a baseline on name tasking prior to the surgery, and a patient that to us seemed like she was fluent with no errors in her speech. But then upon more detailed analysis, Dr. Sapsevitz noted some anomia, were finding problems, especially she could baseline her. So when she was testing her in the OR, she knew if that was already her baseline, or we were seeing further deficits related to the surgery or the stimulation.
Yeah, I mean, I'll keep it brief in the interest of time. Naming is kind of the go-to task that most people use to map language in the OR. It would be very hard to do that reliably with this patient. She had a very, very poor naming performance on baseline. So we think outside the box a little bit, and we used a test where she heard sentences like, can a monkey, or do monkeys live in trees? Can a shark fly? You don't have to retrieve a name. There's no lexical retrieval. You just have to be able to decode the meaning of those sentences so we can use it to monitor semantics without the requirement of finding a name for something. So that we relied heavily on that as we were resecting to see if we were damaging that semantic network.
Thank you so much, sir.
Yep.
And one last question before we go to the case. So the auriculotemporal nerve is a branch of, and you can see here, this is part of the blocks that we do, the scalp blocks that we do before the case. Our great colleagues in anesthesia, they take care of those. Supraorbital, supratropical, auriculotemporal. So V1, V2, V3, or 7. And the answer is V3. Okay, so let's move to the case. Standard exposure. We turn the craniotomy flap there. We remove the bone at this point, as we saw many times. Injection of the local anesthetic in the dural leaflet before proceeding with opening of the dura. And you can see here, cruciate fashion. Then at this point, we place the circular grid. We started recording and monitoring. And here you can hear Dr. Sapsevitz on the other hand, Dr. Q stimulating. We start at 2 million pounds. We went all the way up to 5 million pounds. This way we were able to safely identify an area of cortex that could grant us a corridor to access this lesion safely. And you can see that during the entire case, we kept the circular grid in place to monitor any potential after discharge. So after identifying again the target there, we proceeded using also the help of neuronavigation with the targeted cortisectomy right on top of our lesion. And then you can see Dr. Q and Dr. Akindura working hand in hand with minimal retraction or retraction along a very small corridor. And they identify, you cannot really see from the video, but there was a pseudocapsule, a very nice plane that they were able to work around and remove this lesion. You can see it there coming almost in bulk. And you can see also the hemorrhagic component. And during all this process where our colleagues monitoring for any after discharges, you can see some activity there that resolved right after resecting the lesion, and we'll see that after, and then we proceeded with standard closure. This is just on the right side. You can see where our circular grid was located, and you can see the 3 red dots. That's what corresponds to some focal sharp waves that were identified on the posterior margin of the circular grid during the case, which resolved, decreased after the resection. This is just a post-op scan. A pre-op on the left side, post-op on the right side. This is pre-contrast, and you can see gross total resection with some minimal blood products, as well as again on the post-op SWI. And fine, gross total resection. We have Dr. Gentoft on the line. He sent us some slides.
Yes, so here we can see that the majority of the tissue here is actually organizing blood products. You can see small little holes, or when you look on the actin stain, you can see small little vessels, and that's part of the organization process of a hemorrhage. It's called something called a Masson tumor, papillary endothelial hyperplasia. However, we do see some actual vessels that are present here, outlined with the red arrows, and you can see those are highlighted by the actin, or that is highlighted by the actin stain. That vessel is disrupted. We don't see a distinct vascular malformation here. However, we do not see any evidence of any neoplasm. So it's just predominantly organizing hemorrhage. is favored to be due to a vascular malformation, though a distinct one was not identified. We did see some, or I did see some vessels that were present that could have been part. However, it can be difficult at times to find a distinct malformation pathologically.
Thank you so much, Dr. Gentot. The patient tolerated the procedure very well. She was discharged home on post-op day number 2. She was intact, as you can see. Her speech was at baseline, clear and coherent with intact repetition. So I think that this case really demonstrates the complexity of lesion located in very eloquent areas, and also on the need of really having a multidisciplinary team involved. As you saw, Dr. Sapsevitz as well as Dr. Tatum, neurophysiology, constantly monitoring in the OR to give a safe resection to this patient. Thank you.
I did have a quick question for Dr. Gentop, actually. How often do you see this where, I mean, I guess, do you think it's just that, you know, it bled more recently and then it kind of disorganized or, you know, defragmented or fragmented the, you know, organized or previously organized, you know, vascular malformation? And I guess how often do you see this? Because I mean, as you saw on the, you know, the video, I mean, it was definitely, I mean, it had the typical appearance for a vascular malformation and the kind of a ball, like an actual, there's actually a well delineated lesion. So what are your thoughts about that? Have you seen that before?
I think why it was so well delineated is that it was so organized. Oftentimes when you have these, when you have a vascular malformation or cavernoma, you have various degrees of hemorrhage. Some that are more organized than others with, you know, hemosiderin deposition. This was all predominantly all organized. As far as how often do I see it fragmented, there are times where I can't be sure whether it's a cavernoma or not, but typically you can tell. And a lot of times the reason that it can be difficult is there's often a lot of cautery effect. Whereas on this one, I did not see that. I just don't really have any other explanation for the hemorrhage here. And the fact that there was, you know, as I showed, a vessel that was there and disrupted and was larger, it could be part of a malformation, but it definitely was not, there was definitely no neoplastic tissue within the tissue.
Okay, thank you.
Okay, very nice, beautiful cases. Any additional questions? Mateus, maybe any comments? How would you do this case in a similar fashion? Would you do it anything differently?
No, I think it's a great case, great discussion. I think it'll be the same fashion. Congratulations, great case. Great
Well,
decision.
thank you, everybody. Thank you, Mateus. And we have a flyer for Monday, I think, Diogo, Andrea. And of course, thank you, Gaetano. Beautiful presentation.
Thank you, JP. Thank you all.
So I think the team is coordinating the flyer for Monday. Oh, beautiful.
Yep, we just got
Perfect.
it, I think.
Thanks, Diogo. So what do we have on Monday?
We'll have Dr. Goyal next Monday. He is the PGY2 here at Mayo, and we'll send the updated flyer with the title of his talk later today. So
Okay.
please join us. It'll be super awesome.
Thank you. Thank you, everybody. Have a nice weekend, and thanks for joining us. Tchau, Mateus.
Thank you. Valeu, João. Obrigado.
Adiós.
Adiós.
Adiós.